Recording in progress.
Good evening, everyone. Welcome to today's Kafirangan Ref webinar number 675 by Dr. Kajri Bhattacharya on central nervous system tumors. It's going to be case based only. Before starting today's session, let's see what we have in the upcoming sessions. Tomorrow in the international webinar, we have Dr. Asfar from the United States Missouri Hospital talking on small bowel obstruction. Next Wednesday, that's 3rd of April, Major Dr. Ashish Chaudhary will be discussing NT scans and beyond. Next Saturday, again, we have a neuro topic by Dr. Divyata Hingwala. Next Sunday, in the international webinar, Dr. Alok Bhatt from the United States is going to talk on navigating the suprahyoid neck anatomy and pathology. These are the free webinars on the meditube.com. You can go through Bhavin Jankaria sir's lectures on ctchestreview.com. You can follow us on social media handles. Coming to today's session, Dr. Kajri Bhattacharya is DM Neuro Imaging and Intervention Radiologist at as an assistant professor at Tata Memorial Hospital, Bombay. Our areas of interest go into neuroimaging, including onco-imaging and head and neck imaging. We are really happy and kind to have her on board today. We have two brave volunteers with us. Dr. Saunthar is here from Sion Medical College and LTMC Medical College in Sion Hospital from Bombay. They would be taking up the cases that Dr. Bhattacharya will be showing. Kajri, are you around?
Yeah, I'm around. Hi, Chinmay. Good evening.
Hi, good evening. Thanks.
Who is the second person? Dr. Sauntar, you are JR1, JR2, JR3?
I'm JR3 in Sion Hospital, ma'am. And
Okay.
with me is Dr. Adarsh is JR2 in Sion Hospital. And we logged in via the same thing so that there will be no echo.
Okay. Okay, great. Fine. Okay.
Okay, all over to you, Kajri.
Okay, thank you. So I'll start my screen sharing.
Yes, please. Yeah.
So any of you How much is your experience in brain tumor imaging? Can I just ask before we start?
Yes, ma'am.
So, Dr. Sauntar, what kind of brain tumors you are seeing at your institute?
Ma'am, in our institute, we had seen almost all the varieties, ma'am,
Okay.
everything. But
Most commonly?
most commonly, we would see meningiomas,
Meningiomas.
and in
Okay.
children, we had seen many pilocytic astrocytoma,
Okay.
hemangioblastoma, and we had also seen many supracellular tumors like pituitary macroadenoma and craniopharyngioma.
Great. Very nice. What about Dr. Adarsh? So, what are the sequences which you routinely use in brain imaging, especially tumor imaging?
Ma'am, routine, we go for routine like normal brain screen, normal brain protocol, like we take flare in axial, we take T2 in coronal, we take T1 in SATS, then we go for diffusion weighted imaging, and further we go for contrast imaging. We also do advanced imaging in the form of MR spectroscopy, perfusion imaging, and diffusion tensor imaging.
Okay, you do DTIs also. So, what cases you specifically do DTIs for all cases or for some specific cases?
Ma'am, high grade tumors, particularly of like GBM or lymphomas, in which there is a high suspicion of infiltration of fibers. So we go
Okay.
for TTI for better surgical planning.
Okay, very nice. Good. So, who will be liking to volunteer for the first case?
Yes, ma'am, I will volunteer.
Who are you,
Okay.
Santar? Okay,
Yes, ma'am.
okay, fine. So, Santar, how do you start with reading a brain image? So, first sequence which you read, what is the first sequence that you read?
Ma'am, flare sequence, I would prefer
You
flare
start
sequence.
with a flare sequence, okay?
Yes, ma'am.
But the thing is, if you look at the brain tumor imaging, and I'll tell you why, the first sequence which you should always look for is a T2 weighted image, okay? So you
Okay,
start
ma'am.
with a T2 for any kind of brain imaging. I would like to tell all my residents who have joined here, the first
Okay.
sequence which you see is the T2 weighted image, followed by a flare, then a T1, then you see the diffusion, then the gradient or SWI, whichever you've acquired, and finally you see the perfusion as well as the spectro, as and when you acquire it. And I would like to mention that we don't need perfusion spectro for all brain tumors, right? So
Yes, ma'am.
some brain tumors only we do perfusion spectro specifically if we are suspecting a particular kind, and we at our institute generally limit it to distinguishing between a grade 2, grade 3, grade 4 tumor or for post treatment. So we get a lot of post treatment cases where we actually need to differentiate between progression, pseudo progression, and radiation induced necrosis, etc. So in those cases, we perform perfusion and spectroscopy. We routinely do not perform perfusion and spectroscopy for all tumors. Okay. So with that in the background, let us start with the first case. So Sauntar, I will give you a history. This
Okay,
is
ma'am.
a 43-year-old female who has no comorbidities, and she has a history of fall in the month of December in 2021.
Okay, ma'am.
Then, obviously, as just a second, can you give me 1 second? Just a second.
Yes, ma'am.
Yeah, apologies. I'm so sorry. So, just as we see in case of any patient who presents with a sudden onset history of fall, we do a CT, and a CT was performed. And apologize, I don't have the images for the CT right now. So, it showed an ill-defined hypodensity in the right frontotemporal region, which was rendered as a non-hemorrhagic contusion. It was thought that it's a small contusion in the right frontotemporal region. After
Yes,
2 months, this patient presents with a history of giddiness, multiple episodes, and then vomiting. And
Okay.
now she has presented with a history of seizure, which has started in October, and at our institute, she presented in December after multiple episodes of seizure. So now we'll start with the imaging. So let me show you the first sequence which I told that we look at in our setting.
Yes.
Okay.
Yes.
Okay. So what is this sequence and what are you exactly seeing? You have to describe.
Okay, ma'am. In this sequence, we are seeing the T2 axial section, ma'am, and
Yes.
in this we can see an ill-defined hyperintense area involving the frontoparietal and temporal region, right side.
Okay.
And it is ill-defined, ma'am, and there is no significant, predominantly involving the white matter, and um, there is midline. There is mild mass effect causing midline, but there is no significant edema in this case, ma'am.
Okay, so you are saying that this is a lesion which is located in the frontotemporoparietal region. So how do you localize a lesion first? We'll start with that. How do you
Yes,
localize a brain tumor or any lesion for that matter, whether it's an infective lesion or a stroke? How do you localize?
ma'am. First, I would like to classify whether it is intraxial or extraxial,
Excellent. Okay.
and
So this is an
after that,
intraaxial tumor or an extraaxial tumor?
it is intraxial, ma'am.
Intraaxial. Okay.
Yes.
Then
And within this, there might be a possibility of infective etiology also, or inflammatory etiology, and
no. But what I'm saying this, how do you localize? So in that, if you have to say that it's an intraaxial lesion, then how do you compartmentalize? It's a supratentorial or an infratentorial, right?
yes,
So in supratentorial, what lobar anatomy you told? So you have told it's a frontotemporoparietal. How? So what part of the brain is this, which I am showing with the arrow? This is
basifrontal,
basifrontal. Excellent. This is
right temporal,
temporal. And
yes,
then this is the anterior temporal pole and the medial temporal, right? So these are the
yes,
areas which are involved. What part of the brain is this?
frontal, ma'am.
So this is the part which is known as insula, right?
Yes,
And this, so when we go up, we don't see anything which is present in the parietal lobe, right? So for
yes,
your convenience, since you told that you are used to looking at coronal images also, so this is
yes,
the basifrontal, this is the
yes,
temporal, some part of the insula is involved.
yes,
So basically the temporal lobe and some part of the basifrontal lobe is the area of involvement. There is no involvement of the parietal lobe. So this is strictly a frontotemporal lesion. Okay.
okay,
So your localization should be absolutely correct. Now you describe the signal characteristics in T2 weighted image. Tell me.
ma'am. It is heterogeneously hyperintense.
Okay. Heterogeneously hyperintense in T2,
Yes,
right?
ma'am.
Okay.
Yes, ma'am.
So then you tell me what are the effects it is causing. So there are some mass effects, right? So first you
Yes,
localize the lesion, then you tell the signal characteristics, and then you tell, obviously you have to first look at all the sequences and tell the mass effect in a later sentence. But
yes,
just for the sake of description, can you tell me what all mass effects this tumor is having?
yes, ma'am.
Tumor or lesion, whatever you want to say, is having.
Is causing mild effacement of the frontal horn of the lateral ventricle, and
Okay, very good.
On scrolling down, we
Yes,
can also see there is effacement of the crural cisterns
absolutely, very good. Then,
and the Sylvian fissure.
uh,
Again,
okay, right. Then, so basically the
there
MC
is
appears pushed up, right?
yes,
Okay.
ma'am.
Then,
Yes, and there is a mild midline shift, I think so, ma'am.
yes, another very important thing which you should remember, that why do these patients undergo sudden deterioration is this thing. Can you see this? This is, what is this known as?
And this is the medial part of the temporal
This is
bone.
basically known as the medial part of the temporal lobe or the uncus, which
Uncus.
when herniates in that region can actually lead to brainstem compression, and patient can suddenly deteriorate, and it can lead to sudden death of the patient also in certain cases if there is very severe compression. Okay, so the
Yes,
aim in this patient would be to somehow relieve this compression by surgical decompression, so that this part which is actually compressing upon the brainstem,
yes,
it goes up outside. So this is very important to mention when you're describing any tumor with a mass effect or any lesion with a mass effect, that whether there is any uncal herniation or not, because it is compressing a very vital part of the brain, right? Right.
yes, ma'am.
So this is the description with T2. So now you would like to see flare, right? As I assume, because you wanted
Yes,
to see the flare in the first sequence. So I would like to tell that we generally acquire a post-contrast flare in our cases, but you will get a fair idea from what I am telling you. One second.
okay, ma'am.
Right. Can you describe it in this?
Yes, ma'am.
Tell.
We can
What
see
does
an
the flare image tell you?
it is not following the, it is not getting suppressed in the flare sequence. So
Excellent. So do you see this one area, one small focus which is getting suppressed? This one, which was hyperintense on T2, right?
yes,
So again,
ma'am.
I'll go back to T2. I'll show you that. So you see, this is the area which was hyperintense on T2. Maybe this is an area which is looking more hyperintense. So we are presuming that these are the more cystic parts of the lesion.
Yes.
And these are the areas which are actually showing some partial signal suppression. Maybe this not so much, but this definitely is showing some signal suppression. So
Yes,
why is this important, Sanket, to tell whether there is any signal suppression and in flare or not?
ma'am. To identify the cystic components to tell there is
Okay, cystic components. And so okay, we'll come back to this because this is a very important part of our description. So what you have said is that basically the tumor looks almost similar in T2 and flare. Now what is the next sequence that you would like to see?
diffusion.
Okay, would you like to see T1? Okay, we'll see T1 later
T1
on.
and
You want to see diffusion or T1? Tell me.
T1, ma'am. T1 and then diffusion.
Okay, great. Right. So this is the T1. So what do you see in T1? So
It
the
is
tumor is,
isodens.
the lesion is
Isodens to the gray matter.
iso to mildly
Hypointense.
hypointense, right?
Mildly,
So these are the areas which are a little bit hypointense. The more cystic parts are more hypointense, and the rest of the areas are almost isointense, right? So it is heterogeneously hyperintense on T2, not showing any signal suppression or flare, and isointense to hypointense on T1. Next, you would like to see diffusion, right? Okay.
Yes, ma'am.
So this is the ADC, and I would like to show we generally acquire exponential. So we generally subtract our images, process our images, and then only send. So I would not be able to show you the V1000 values in majority of the cases. This is the exponential ADC, which we all know is the subtracted value of the true diffusion, but that is the V1000 value minus your ADC, right? So that gives you the true area of diffusion restriction. And along with that, I can also show you the ADC map. So do you see any obvious diffusion restriction in this lesion?
No, ma'am.
No, right? Okay. So this is the ADC map. There are really no significant areas, maybe a small at the part of the periphery of this, but there are no obvious areas of diffusion restriction, right? What is the next sequence you would like to see?
Contrast.
Would you like to see gradient? Is there any role of that?
Yes, ma'am. Gradient sequences and then contrast.
What do you see in gradient?
Any calcifications or any hemorrhage, any hemorrhagic components within the lesion.
Okay. So why is that calcification or hemorrhage important, Sauntar?
We can characterize certain lesions based upon the whether calcifications or
okay. So what are the tumors in the brain which show calcification? Any, just one or two if you could name.
Craniopharyngioma, meningioma.
Okay.
Astrocytoma.
What kind of astrocytoma shows calcification? Do all astrocytomas show calcification?
No, ma'am.
What kind of astrocytomas show calcification?
Mainly.
So if you look at the astrocytomas, generally the astrocytomas, so can you just tell me before we go further in our discussion, do you have any idea regarding what is the latest WHO CNS 5 classification of brain tumors? Any idea how the tumors are classified and reclassified in the current classification system? So the thing is that it is very important for you to understand that now the emphasis from 2016 and then now 2021, it is completely shifted primarily to the molecular characteristic of the tumor, right? So if you look at the astrocytomas, and then they get again divided into pediatric and adult age groups. So the adult astrocytomas are primarily driven by mutation which is known as IDH mutations, right? And on basis of IDH, there are some few other mutations like ATRX and TP53 and 1P19Q, which determine that what the tumor is going to behave like. So even if, so in histopathology, a tumor is looking like an oligodendroglioma. If it is not showing 1P19Q co-deletion, it is not an oligodendroglioma anymore. Okay, it is an astrocytoma. Okay, so the astrocytomas are now classified into in adults and pediatric. In pediatric, again, they are divided into gliomas are divided into pediatric high grade gliomas and pediatric low grade gliomas, and they are all classified by their driver mutations. Okay, so some have MAPK mutations, some have BRAF mutations. So all are delineated by their mutations. Now, why I'm talking about these mutations in this particular case is that you will come to know that the lesion which I'm showing you has particular imaging features which can guide you towards what kind of tumor you are looking at on the basis of molecular profiling also, right? So before we
Okay.
go to this discussion, when we will discuss the differential diagnosis, we'll go to that. So in this
Okay.
particular case, do you see any calcifications or bleed?
No, ma'am.
Not
Yes,
much,
sir.
right? One or two speck. Okay, so
Yes.
these are not very convincing of any calcifications or bleed. Next,
Contrast sequences.
okay, contrast. What do you see in contrast? Just adjust it
Ma'am,
one second.
it is not showing significant contrast enhancement.
Yeah, so there are
And
a few areas of
yes,
well-defined contrast enhancement, but not much,
yes,
right?
yes,
Not much contrast enhancement in this tumor, in this whatever lesion we are looking at. Okay.
yes,
So let us look at this FSPGR also. What is the sequence, Santa?
and T1 pre-sequence post sequence.
Yeah, so if you can appreciate here, there are a few areas of patchy contrast enhancement in the posterior part of the tumor, right? Where it is showing some cystic necrotic change. Okay.
Yes,
Right.
ma'am.
So on the basis of this, would you like to make a differential diagnosis?
Ma'am, I would like to give a low-grade glioma.
Okay. So if you tell low-grade glioma, I am pretty sure that it will be very much acceptable to the external examiner, because at this stage, if you're telling a low-grade glioma, then it's fine. But do you know that pilocytic astrocytoma is also a low-grade glioma, but it does not fall under diffuse glioma, right? So you have to first clearly tell whether you're looking at a diffuse glioma or a circumscribed astrocytoma, circumscribed glioma.
Okay.
What type of tumor you're looking
Diffuse, ma'am.
at? Diffuse. So
Yes,
what is the difference between circumscribed and diffuse? The borders are much more well
borders.
defined in a circumscribed tumor, and
Yes,
the borders are not well defined from the adjacent white or gray matter. It's a diffuse tumor. So this is
diffuse.
a, what you mean to
Diffuse.
say is a low grade diffuse glioma, right? Okay.
Yes, ma'am.
So if I want to ask you a little bit further,
Yes,
what do
ma'am.
you mean by low grade, and what do you mean by, what do you, which one would you prefer? What are the types of diffuse gliomas you know of in an adult patient? So I told you this patient is 43-year-old. What are the types of tumor, diffuse, low grade glioma you expect in a patient of this age group?
Ma'am, adult astrocytoma, oligodendroglioma.
Yes. So these are the two. Don't speak of anything else. These are the two histologies which we see. First is an astrocytoma and second is an oligodendroglioma. And this case is a very, very good learner in telling you that why this, how do you differentiate between an astrocytoma and an oligodendroglioma, right? Okay. So you are telling it's a low grade diffuse glioma, and it could be either a low grade diffuse astrocytoma or a low grade oligodendroglioma, right? Now, first,
Yes,
then you tell me, why are you telling that it is a low grade tumor? What are the features of a low grade diffuse glioma, or whether it's an astrocytoma or an oligodendroglioma? What are the features that tell you it's a low grade tumor?
ma'am. In contrast enhancement, ma'am, it shows very mild enhancement. So
Okay.
I would give low
So
enhancement or
contrast
soft.
enhanced. What are the other features of a high grade diffuse glioma? For example, a GBM. What are the imaging features of that? I mean to ask indirectly that.
Ma'am, it shows vivid enhancement. Necrotic areas within may cross the midline. Diffusion
Okay.
restriction. Diffusion restriction.
Okay. So the
Yes,
first, the two, the if you look at all the sequences in this particular tumor, so if I tell you that you need only 3 sequences to tell what is the grade of a tumor, then those 3 sequences will be a T2, a diffusion, and a post contrast. Okay, these are only the 3 sequences where you can actually make out what is the grade of the tumor. So, for example, if you have a tumor which has a high cellularity, it is likely to be a high grade tumor. What do you think is the T2 signal of that tumor?
T2 hypo.
It becomes,
T2 hypo.
as the cellularity increases, it starts becoming more and more iso-intense and then hypo-intense. Very good. Second is, what is the diffusion signal of a high grade versus a low grade tumor?
High grade, it will show diffusion restriction.
Absolutely. So it will show diffusion restriction, and low grade will not show diffusion restriction. Very good.
Yes.
The third is the contrast. So basically, a low grade tumor generally shows minimal to no
Minimal.
enhancement, and a high grade tumor generally shows patchy areas of enhancement. And generally, these enhancement are the areas which are showing high cellularity, that means they're hypointense, and these are the areas which show diffusion restriction, right? So the high
Yes.
cellularity areas generally show diffusion restriction. So you are correct. This is a low grade tumor.
Yes,
But
ma'am.
now the most important question arises. You want to make it an astrocytoma or you want to make it an oligodendroglioma, and what will be your points supporting each of the diagnoses? If you don't want to put it into any of the other category, then I will tell you. But if you have to put your bet onto one, then which would you like to bet?
It predominantly involves the white matter, so
Okay,
astrocytoma.
astrocytoma. Okay. What about Adarsh, right?
Yes, ma'am.
Adarsh, you have any answer?
Uh,
Astrocytoma or oligodendroglioma?
Ma'am, I would also like to go with oligodendroglioma because, astrocytoma, because
Okay.
oligodendroglioma generally are present at the involve gray white matter, and
Okay.
also there are areas of calcification.
Okay, very good. So the points which you have given are excellent. Okay, so I would also say that these are the points which you have put are good. But if you just look at this tumor very carefully, this tumor is not entirely a white matter tumor, right? So if you look at the basifrontal region, this is definitely involving the cortex, right? So
Yes,
the thing, if you are saying that it is entirely involving the white matter, it is not true, because see, so what is the difference between astrocytoma and oligodendroglioma? What is the basic cell of origin of these two tumors?
oligodendroglioma also from uh, glial, both are glial tumors, ma'am.
Both are glial tumors, yes.
Astrocytoma arises from astrocytes, and oligodendroglioma arises from oligodendrocytes.
So these are both supporting. So basically, these are all supporting structures of your neurons, right?
Yes,
So
ma'am.
a tumor which is only located in the cortex is a tumor which is likely to arise only from the neural cells, right? So basically, it could be a what do you say, that glioneuronal tumors. These are mainly located only in the cortex. But
Yes.
any of these tumors, as an astrocytoma or an oligodendroglioma, definitely will involve some part of the white matter, and it can predominantly arise from the white matter, because these are all supporting cells which are present in the white matter as well as the gray matter, right? So definitely you
Yes.
are correct that oligodendroglioma involves more of cortex. Astrocytoma involves more of white matter. In this, you can say that probably white matter is more involved, but definitely you can't miss the fact that there is swelling of the cortex in these areas, right? In the major part of the
Yes.
tumor, that is the epicenter of the tumor, which is the temporal lobe and the basifrontal lobe, you can actually see the cortex is not at all well seen. The cortex is also swollen up. First thing.
Yes,
Second,
ma'am.
yes, you told that there is no calcification. So do all oligodendrogliomas show calcification?
No, no,
Okay,
ma'am.
any idea about what percentage of oligodendrogliomas show calcification? Leave it. So this is maybe a sort of homework for you. You can go and read up that how many percentage of oligodendrogliomas show calcification. So why
Yes.
was I asking whether what is the importance of looking at the flare signal in this particular tumor? Any now if you go back, any sign which you know of which can help you to tell what type of tumor you're looking at? Have you heard of something called as the T2 flare mismatch sign? So let me tell you very clearly, there is a sign called as a T2 flare mismatch sign. It is a very, very well described sign. So if you go and read up the radiology books, it will tell you that if you are looking at the T2 of a tumor and the T2 looks like this, and the areas which are hyperintense on T2, they show inversion in flare, and that inversion part carries more than 50% of the tumor. It is called as the T2 flare mismatch. T2
Okay.
flare mismatch is a 100% specific sign of a IDH mutant astrocytoma. Do you see it in this? You don't see, right? Do you see that? Do you see the T2 flare mismatch? Is there any inversion, significant inversion more than 50% of the tumor? It is not there, right?
No, ma'am.
There is no T2 flare mismatch in this particular tumor. So if the T2 flare mismatch is present, you can be 100% sure that you are looking at a low grade diffuse astrocytoma, which is IDH mutant 1p19q non-codelated. That means it is not an oligodendroglioma, it is an astrocytoma. In
Okay,
this, that sign is not present. Okay, so the cortex is more likely involved. It's a more diffuse tumor. It is not showing any T2 flare mismatch. So that means that probably we are looking at more of an oligodendroglioma, and that is the crux of this, me presenting this case to you, that why
okay,
it is important to look at the T2 flare mismatch. That is extremely important. So if you say that some part of the tumor is showing some heterogeneous enhancement, so this, the histopathology of this particular tumor was an IDH mutant oligodendroglioma, that is 1p19q co-deleted. 1p19q co-deletion is an absolute must to say that it's an oligodendroglioma or not, and it was that. It was between grade 2 and grade 3. And you can tell that it was between grade 2 and grade 3 because there were some patchy areas of post-contrast enhancement in the posterior part, right? So
yes, ma'am.
this is actually an oligodendroglioma. Oligodendroglioma, why? Because this was involving the cortex. The epicenter of the tumor was in cortex, definitely involving, it's involving a large part of the white matter. There is no calcification, I agree with you, but definitely that low grade astrocytomas, if it is an IDH mutant astrocytoma, which is 1p19q non-codelated, that means that astrocytoma, which we conventionally say if it was that, then the T2 flare mismatch sign is very helpful. I'm not saying it is around 40% sensitive, but it's 100% specific. But the look of this tumor is actually so, but obviously diffuse astrocytoma, oligodendroglioma is the first differential, but astrocytoma is definitely an important differential which you have to keep. But I'm telling you what are the features in favor that tell you that this is an oligodendroglioma and not an astrocytoma, right? So apart from that, what other things you would like to see? We generally do not look at perfusion and spectro that much. The perfusion is has been performed in these areas, and if you look at the RCBV, it is almost same. There is not much of an elevation of perfusion. It is
Yes,
around 31 and 30, and there is some choline peak there, but not much. So this generally does not help you. We already know it's not a very high grade tumor, and but the crux is to tell you about the T2 flare mismatch sign. And I would request all the residents who are attending this to please go back and read the T2 flare mismatch sign. It is extremely helpful in telling you whether you're looking at a low grade diffuse astrocytoma 1p19q non co-deleted status or a co-deleted status, right? So which is one co-deleted is your astrocytoma and co-deleted one is your oligodendroglioma. Okay?
okay, okay,
Right.
ma'am.
Very good job. So now I'll move to the next case with Adarsh.
Yes,
Okay?
ma'am. Yes, ma'am.
So again an adult patient, and this one is okay. So again, I'll start with T2. I'll tell you the history. So this is a 64-year-old man who has, again, no comorbidities, a family history of cancer. And the patient presents with a history of imbalance during walking for the last 3 months. And he has now presented with weakness of the left upper limb and deviation of the angle of mouth to left. Okay. So let us see the image. So I'm scrolling it once and then you can start describing. Right. This is what we see. So please tell me what you are seeing now.
Uh, Ma'am, there is a well-defined uh, T2 hypointense lesion noted
Okay.
in the uh, right frontal and basal ganglia region with surrounding T2 hyperintense area suggestive of edema. In the lower sections, it was also seen extending along the peduncles to cerebral peduncles.
Okay, great.
Uh,
Then,
then it is also seen extending in the upper part of pons.
so this is the edema, right? Or this is the tumor? What do you want to say?
This is edema, ma'am.
Okay. So the edema is extending below, and the tumor is extending. The lesion is extending till which part?
Peduncles, right cerebral peduncle.
Okay. Okay. So this is the T2. So if it is a hypointense lesion, what are you expecting this lesion to be? A high
Ma'am,
grade lesion or a low grade lesion?
high grade lesion, because
Okay.
generally
So
increases the
this is
cellular.
the case when we are looking at a tumor. So if I tell you this is not a tumor, then what could this lesion be?
Ma'am, it can be an uh, abscess or
What kind of abscess?
uh, cerebral abscess.
Yes. So what are the general characters of a cerebral? What types of cerebral abscess do you know of?
Uh, Ma'am, pyogenic cerebral abscess,
Okay.
fungal cerebral abscess,
Okay.
uh, also TB, caseating
Excellent.
granuloma
Very
with
good.
central
We should not
liquefaction.
miss TB in our country at all. TB is a very good gen. And anything else? And protozoal and other abscesses are there. Okay, so basically you have to think about predominantly pyogenic tubercular fungal. So if you are, I'm saying that this is, so for a moment please forget that this is a tumor. You are just given this a session on tumors. Just forget, just go blindly and say that this is a hypointense lesion, and which is appearing predominantly hypointense and having an area of central necrosis. So, what next sequence would you look? Would you try to look uh,
Ma'am,
after this?
flare.
Okay. So this is the post contrast flare. As I already told you, we generally acquire. Oh, I'm good. I'm so sorry. 1 second. What's happening? Yeah. Yeah. So we generally acquire a post-contrast flare in our setting. So just ignore this is some contrast enhancement as you can see. But this is okay. Just describe this.
Ma'am, significant suppression is seen on flare.
Sorry.
No significant suppression is seen on flare.
So if anything is hypointense on T2, does it show suppression? Are you expecting to see suppression? No, right? So something which is hyperintense on T2 and has fluid content will show suppression, right? So generally, in this particular tumor, I agree with you. So that's why I told you that flare is not very good sequence of tumors, right? So when you have decided in your mind that what kind of tumor it is, and then you want to look at the extent of the tumor, then flare is an important sequence, because flare tells you about leptomeningeal enhancement, some subtle focal hyperintensity which we miss on T2. But when you have to make up your mind regarding which tumor you're looking at, there is actually not an ideal sequence. So first is T2, and second sequence which you look at in case of these is a diffusion. So let me show you the diffusion in this case. Okay, let me show you. Let me show you the T1 also. So can you describe the T1?
The lesion is predominantly T1 hypointense.
Okay. Okay. Predominantly T1 hypointense with some perilesional whatever hypointensity, that is the edema. So next is the most important sequence which I told you is this.
This G.
Yes, tell me. What is the diffusion?
So, ma'am, on fusion, it is showing restriction.
Okay. So if you saw clearly, so the central part of the lesion was
Is
showing
not.
hyperintensity, so that is not showing any restriction. The rest of the lesion is showing diffusion restriction. Okay. So let me show you the ADC also, because that has to be always seen in togetherness. So yes, this is this lesion which is showing restriction. The third sequence which I told you is important is post contrast, right?
Yes.
So what are you seeing here?
Ma'am, on post contrast imaging, enhancement, homogeneous enhancement is seen with the central area which is non-enhancer.
Oh, okay, very good. So so I'll show you the other sequences. So now you have seen the T2, you have seen flare, you have seen T1, you have seen diffusion, post contrast. I'll show you the gradient also once. Yeah, what do you see?
Ma'am, there is an area of blooming,
Small area, small focus of blooming,
focus of
possibly
blooming.
the area which is showing some hyperintensity on T2, right?
Yes,
Okay, fine. So, what would be your differentials on whatever imaging you have seen?
Ma'am, because of diffusion restriction and vivid enhancement, I would go for a high grade tumor like high grade gliomas and
Okay,
lymphoma. I'll also consider lymphoma because it is hypointense on T2.
okay, okay. Very good. No, I that's excellent. So basically, before we further go into discussion, I'll tell you that this is a lymphoma. So, what are your points in favor of lymphoma?
Ma'am, T2 hypointense.
Okay,
Uh, um,
T2 hypointense, right? So this tumor is so much different from the tumor which we were previously looking at. The signal is T2 hypointense. So second point in favor of lymphoma.
Ma'am, diffusion restriction and homogeneous enhancement.
Homogeneous post contrast enhancement. So it is very important for the residents to remember this post contrast enhancement. This is a very, very homogeneous and pooling kind of post contrast enhancement, which is rarely seen in any kind of gliomas. So gliomas generally show central areas of necrosis, large areas of neovascularity and bleed. So if it's a very vividly enhancing glioma, then it is generally a grade 4 glioma, and those grade 4 gliomas, diffuse gliomas, they show large areas of necrosis and heterogeneous post contrast enhancement. This kind of a solid post contrast enhancement is seen in predominantly lymphomas. So what are the imaging features of say a glioblastoma, and what are the fundamental difference between a glioblastoma and a lymphoma? So if you tell me, so if you say, for example, I'm talking about a grade 4 glioma, that's either a IDH mutant grade 4 astrocytoma or a glioblastoma, that means an IDH wild type or IDH mutant, whatever. What are the two basic imaging features that we have to see to tell that it's a grade 4 tumor in imaging?
Ma'am, high grade glioblastoma multiformes generally have peripheral rim-like enhancement and central non-necrotic
Necrosis.
central
So
necrotic area.
first thing is necrosis, and second thing is microvascular proliferation. Extremely, extremely important. Please put this in your mind. So if you are looking at a tumor which is having areas of central necrosis, you have to go back and see your SWI sequence, because SWI will show your areas of neovascularity, right? That pattern of neovascularity means neoangiogenesis. That means those black signals which are appearing around the tumor, that suggests neovascularity, which is never seen in case of lymphoma. Lymphoma does not form those neoangiogenic channels. Neovascularity is the feature of a glioblastoma. Neovascularity and necrosis, that is microvascular proliferation and necrosis, these are the imaging features which tell you whether you're looking at a glioblastoma or a lymphoma. So, if you just extend this to the advanced imaging features, what is the difference in the imaging feature or perfusion of a lymphoma versus a glioblastoma?
Uh, Ma'am, cerebral blood flow will be elevated in cases of glioblastoma.
Okay, then
Uh, in,
in case of lymphoma,
in case,
so you told that cerebral blood flow is elevated in case of glioblastoma,
yeah,
right? Is it
yes,
cerebral
ma'am.
blood flow or is it cerebral blood volume?
Sorry, ma'am, blood volume.
What is the difference between two? What is the difference between cerebral blood flow and what is cerebral blood volume?
Uh, Ma'am, blood flow means per unit blood which is received,
Per unit what?
per unit of
What is the unit of blood flow and what is the unit of blood volume?
per,
Okay, so basically, if you look at the central volume principle, CBV is equal to CBF into MTT, right? That means the time. So if you divide it by a unit of time, you get the flow. That means per second how much blood is going. And blood volume means the total volume of blood in spite of that is there in the tube. So basically in tumors, what happens is the volume of blood, so not necessarily the time is important, but the total volume of blood that is there in that reaching in that particular area of tumor is important, right? So for tumor, cerebral blood volume is the more important feature. You have to remember it like that. For stroke, cerebral blood flow, that means per second how much blood is going into that area which is having stroke is important. So for stroke, CBF is important. For tumor, CBV is important, right? So you told that CBV is elevated in case of glioblastoma. Very correct. What happens in lymphoma?
I'm sorry.
So you don't know. So basically, generally what happens is lymphomas, they show a low perfusion, right? So I'll show you the perfusion imaging of this. Can you see how cold it is?
Yes, ma'am.
Glioblastoma does not look like this ever. So perfusion imaging is very helpful. So when you're looking at a high grade tumor and you're not sure what you're looking at, then you should go and look at the perfusion. Okay. So perfusion will tell you that this is a very cold area, right? So therefore, definitely the perfusion is not elevated. So if it's a glioblastoma, perfusion will be elevated. This is a cold tumor, the perfusion is not elevated. Apart from that, what are the any other special imaging feature of in perfusion you can tell that will help you in telling whether it's a lymphoma or not? Okay, I'll show you in another companion case that particular feature. Okay, so in this particular case, you're seeing that the perfusion is low and the lesion is showing intense post-contrast enhancement with small central area of necrosis. There is significant perineal edema. Would infection come into your mind? Does any kind of infection present like this, look like this? What is the location of this lesion?
Gangliocapsular region.
Gangliocapsular region, right? So any kind of abscess which presents in this area?
Toxoplasmosis.
Toxoplasma, very important. So when you are looking at, especially in case of immunocompromised patients, when you're looking at this lesion, you can never be sure whether you're looking at a lymphoma or a toxoplasma, because obviously the one feature which will help you in telling is the amount of diffusion restriction. So diffusion restriction will be much more in case of toxoplasma, so in much more in case of in lymphoma, because it's a high grade tumor, whereas even if it's a toxoplasma abscess, the grade of ADC will be higher. So basically, you have to know the ADC values also. So the lower the ADC values, the more chances that it is a lymphoma, and worse the prognosis. So ADC has a prognosticating value also. Second is, in this kind of a necrotic lesion, if it's an immunocompromised patient, you have to be very careful whether you're looking at a toxoplasma abscess or not. Okay. So so other than that, any other abscess can look like this? What is generally the location of a lymphoma? What is location of the generally where what are the areas of the brain which are affected by lymphoma?
Ma'am, generally their predilection for the periventricular white matter.
Excellent, very nice. Then and the
these,
basal ganglia, right? So basically,
yes,
the
ma'am.
deep brain and the periventricular white matter is the area which are most commonly affected by lymphomas. And so that's that. We leave it at that. So any other infective lesion you think that can look like this in T2?
Ma'am, TB.
TB and fungal, both. Okay, so a tuberculoma can also look like this. A fungal lesion can also look like this. How will you tell that whether it's a tuberculoma or not? What tells you that this is not a tuberculoma?
Ma'am, homogeneous enhancement.
Very good.
Uh,
And intense diffusion restriction in the entire
yes,
lesion, right? So generally, the tuberculoma, when it's in the caseous phase, when it is hypointense on T2, does not show diffusion restriction, does not show intense post-contrast enhancement. When it's a tubercular abscess, then it will not show this much hypointensity. It will become hyperintense like a pyogenic abscess with a hypointense rim. What tells you that this is not a fungal abscess?
Ma'am, there is no T2 hypointense rim.
Okay, right. And what kind of diffusion restriction is seen in a fungal abscess? Do you have any idea regarding? So basically, a pyogenic abscess shows a smooth central diffusion restriction. A tubercular abscess also looks like that, with it shows a smooth thin rim enhancement. Whereas a fungal abscess can actually look as shaggy as this on T2, right? It will show shaggy rims, it can appear hypointense, and it will show some diffusion restriction. But the post contrast enhancement one is very dirty, and the diffusion and restriction is generally seen in the shaggy rim, because those are the part which are containing the fungal elements. So that is the part which shows diffusion restriction. So central diffusion restriction is seen in pyogenic and tubercular abscess. Peripheral rim of diffusion restriction along the fungal elements and dirty shaggy peripheral enhancement is seen in fungal lesions, right? So you see, on the basis of T2 diffusion and post contrast only, we can make all the differentiations. We actually do not need any other sequence. Okay, we need to go in the other sequences just to make up and fix our mind whether what we are looking at as true or not. Okay, so now if we go to the companion case of this, I'll just show you another companion case to show you the importance of perfusion in this particular, another interesting find in perfusion. So let me show you. Okay. So I would like this others only can just answer this. What are you seeing?
Hyperintensities are seen in predominantly in left subcortical and deep white matter of parietal region, and uh, it is also metrically involving both the subcortical and deep white matter, predominantly on left side.
Okay. Okay. So I know that this could be really confusing when I show you the contrast and diffusion, right? So let me show you the contrast. I'll not go into the diffusion. Just let me show you the contrast. What are you seeing here?
Areas of enhancement, periventricular enhancement is seen.
Mhm.
Also, there is nodular enhancement in the upper part.
Just let me come back to the T2. What are you seeing here? So actually now what we have done, we have got is we have missed these areas, right? So these are actually the T2 isointense to hypointense areas, and these are actually the tumors, right? So this is there in the periventricular white matter going along the septum pellucidum, and it is involving the tips of the frontal horns of both lateral ventricles, right? These are the areas which are actually the neoplastic area, and these are all edema. So this is a companion case. This is also again a lymphoma. What tells you this is a lymphoma? Because it is involving the periependymal and periventricular white matter, as we discussed previously, right? So this
Yes.
is again showing. So basically for lymphoma, if you look at the T2 diffusion and post contrast, that gives you the diagonal. Post contrast is extremely helpful in telling you that this is a lymphoma, because this intense post contrast enhancement is seen only in case of lymphoma. So, but the interesting feature which I wanted to show you was this one, right? Can you just comment what we are seeing now, right? So this is the perfusion from this particular nodule, which is the largest and the most intensely enhancing nodule. Can you just see what does the graph look like? This is very dark. This is definitely obviously hypoperfused as we compare with the rest of the normal adjacent white matter. But what is happening with this graph?
Ma'am,
So generally, this is the graph of perfusion, right? So this is the blood incoming. So this is the blood incoming. This is the perfusion of the brain and whatever area you're looking at. And this is the blood going out of the venous system, right? This is how the graph looks like. This is known as the arterial input function of perfusion map. Generally, whenever you are seeing a tumor, you will see this going like this, then coming down, and then there will be some leakage, because in tumor, there is a breakage of blood-brain barrier, right? So this line goes down, and the more down it goes, the more higher is the RCBV as well as the RCBF in the tumor. Okay, do you know how to read perfusion maps?
ma'am,
Others?
ma'am, not much used to it till now.
Okay. So basically, so I'll just tell you. So if you're looking at a high grade glioma, what happens is this line goes like this, then it goes like this, and then it falls flat here. And this is the area which is the gap, which is basically because of the leakage within the tumor, because of the breakage of the blood-brain barrier. In this case also, lymphoma also, there is a breakage of the blood-brain barrier because we see the enhancement, but somehow you can see this line overshooting the baseline and going up. Okay, so this is a very very characteristic feature of lymphoma. If you see this in a particular tumor which you are suspecting in lymphoma, you can be very well sure that maybe you're looking at a lymphoma only. This is called as the overshooting of the peak signal recovery over the baseline. This terminology is specifically used in our AJNR 2011 paper where it was first described. And this particular phenomenon is seen only in lymphoma. So generally in high grade tumors, we see this leakage. It falls short of the baseline. Here it overshoots the baseline and goes along this. Okay.
Yes,
So this is a hyperperfused tumor where there is overshooting of the baseline. The peak signal recovery overshoots the baseline. And this is a characteristic feature of lymphoma. Why does it happen? Because the intense post contrast T1 enhancement. So generally, what kind of perfusion we perform in our machines? What are the types of perfusion? Any of you can answer, Sauntar or Adarsh. What are the types of perfusion studies you perform?
brain we do, ma'am. Then
Yes.
for breast lesions we'll do.
So basically, perfusion in brain, we perform it in three techniques. First is the DSC perfusion, which is the T2 star weighted technique. Second is the DCE perfusion, which is a T1 weighted technique. And third is the ASL or the arterial spin labeling, which does not use any form of contrast. Okay. So these are the three imaging techniques of perfusion of brain. When we are looking at this, generally the types of the perfusion which is very well established in brain tumors is a DSC perfusion or a T2 weighted or a T2 star weighted. And what happens in case of lymphoma is that intense post-contrast T1 enhancement, it interferes with the T2 star perfusion, and therefore this is an erroneous reading which happens. If you do a T1 weighted perfusion in brain, this will not happen. You will again see the hypoperfusion only. But this
Okay.
overshooting of baseline happens because of the some artifactual interference between the T1 post-contrast enhancement and the T2 star effects of perfusion. Okay, so this
Okay.
will help you when to say that you're looking at a lymphoma. Interesting. One
Yes.
more up for one more case.
yes,
Yes,
ma'am.
ma'am.
Or we should finish it.
No, ma'am.
One more case.
One
Yes.
more case. So
Yes.
this is actually, I'm not expecting you to make a differential at all, but I'm just going to tell you that how what strange kind of presentations a brain tumor may have. Okay, so just
Okay.
look at this case. Any of you can answer, whoever is comfortable.
Yes, ma'am.
By the way, very nicely told, both of you. Just you need a little bit of brushing up of brain tumors, and it's really nice. I congratulate you both. Okay, so any of you can just answer this one. So this is, I'll just tell you, this is a case of 2020 when the child was 11-year-old female, and she has a young brother, a younger sibling who has had a brain tumor at the age of 3 years, which later on was turned out to be a cavernous hemangioma. Then she has a history of blood cancer in her maternal grandfather who died at the age of 55 years. She herself is a known case of T cell lymphoma, T cell leukemia with mediastinal
Okay.
mass. She is already on some treatment, so she is receiving some chemotherapeutic agents for that T cell lymphoma, and now she has presented with seizures. Okay, so
Okay,
let us
ma'am.
look at the imaging. Can you describe? Are you seeing something? Soundher?
Yes, ma'am. We can see an ill-defined isointense area in the left frontal region, ma'am.
Mm-hmm.
Hyperintense compared to the gray matter, and
Anything else you are seeing? Are you seeing something here? Something here?
yes,
Yes, what are these? So whenever you're looking something which is very close to the CSF, na, it is always better to look at the FLAIR image. That will
image.
definitely, once you suppress the surrounding CSF, it becomes very clear. So this patient obviously was very, she had seizures and she was not very cooperative when we performed the study. And this is how the FLAIR looks like.
Okay, ma'am.
How does it look like? What can you see?
You can see the hyperintense areas in the left frontal, left parietal regions.
Are you seeing
Then,
something here
yes,
also, right side?
in the right side also, yes, ma'am.
Okay.
Near symmetrical.
So what is the distribution of these lesions?
Subcortical, cortical and subcortical areas,
Excellent,
ma'am.
very nice. So these are cortical, subcortical lesions along with whatever is seen here. Okay.
Yes, ma'am.
Okay, so what are the first differential which come to your mind when you see bilateral but asymmetrical lesions involving the cortex and subcortical white matter in a patient with seizures?
Ganglioglyoma, oligodendroglioma.
Which part of this is tumor? You are seeing extensive lesions, right? Will you
Yes,
think
ma'am.
of tumor first or you will think of something else? Let me show you the diffusion. There is no restriction anywhere. Okay.
Okay, ma'am.
Let me show you the contrast. I don't know whether we acquired contrast here. There is not much of a contrast enhancement also. Right. No contrast enhancement. And this is limited imaging which we did because the patient was uncooperative.
Okay, ma'am.
So mainly, so what I mean to say is, why do these lesions appear bilateral but asymmetrical and they are not showing any diffusion restriction? So what would you think of in this patient who has seizures? Acute seizures, when the patient has presented in the casualty with seizures. It's not like there is a history of seizures and after some time she is presented with seizures in the casualty. And she has a
Press,
history of exposure to chemotherapeutics.
press, maybe press,
Very
maybe
good. Very
post-ictal
good.
changes.
Very good. So that is what I want to say, that whenever this kind of a patient presents with in casualty with a history of chemotherapeutic agent or a very high BP, then you have to think of a press because you're looking at cortical, subcortical, bilateral symmetrical lesions. But obviously there is one lesion here and there is some hyperintensity in the left thalamus also. Okay, and this is a very, very enigmatic case. It was not easy for us to also diagnose in one go, but then I'll just show you the evolution, then how it has grown.
Okay.
Okay, so let's go to the next imaging. So this patient again presented with some visual symptoms, so her optic nerve imaging was also done. Can you tell what you're looking at now in the brain? Don't concentrate on the optic nerve, just tell what you're looking at in the brain. So that ill-defined lesion is seen, right?
Yes,
Okay.
ma'am. It's persistent.
Yes, just let me show you the flare. Now that she has the seizures have been controlled, we are seeing better quality images. What are you
Yes.
seeing here now?
Um, cortical thickening, we can see.
There is some cortical so there is some cortical thickening, there is some cortical edema which is present, but somehow the areas of cortical signal change which were present in the left parietal have now gone, right? And there
Yes,
are
ma'am.
some new areas of involvement which are looking here. This
Yes,
lesion
ma'am.
and this area are still there. So we were
Still there.
still thinking that possibly we are looking at an evolving phase of press only. Okay. I'm sorry, we don't have detailed imaging of this patient in brain because we were actually not anticipating any tumor. But I'll show you the gradient. Gradient is important because sometimes press presents with bleeds. So you have to see whether any bleeds are there or not. And obviously we have to acquire a diffusion at any time when we are looking at a brain lesion because we have to see whether there is any diffusion restriction, new onset or not. So, but there is no diffusion restriction. Obviously, in a patient with ictus, if there is diffusion restriction, then we have to think of status epilepticus or something or post-ictal change also. So that is also not there. There is no bleeds. But then
Okay, ma'am.
the evolving signal changes are there in the brain in T2 and flare. Okay. So this was Jan 3rd, 2021. So first was December 16, 2020. Next was Jan 3rd. Then we moved to, these are the other patients' MRIs. Then we moved to September 4th.
Okay.
Okay. So this is almost a year after that. What are you seeing here? So again, that ill-defined lesion which we are seeing in the left frontal is there. Maybe it has little bit become more prominent in the basic frontal regions, but the lesion is still there. Other
Lesion
than
in the right
that,
side was is not
they have
visible.
they have now gone mostly, right?
Yes, ma'am.
Okay, so we will just go back to the flare and just see what is the better delineate these lesions. Okay. So this lesion is still there. This lesion is still there. Rest of the lesions have gone. So possibly we were correct in the first go that was press. but we were
Yes,
still not sure that what is this and what is this, right? If you
yes,
see another one, there is something appearing here in the temporal pole on the left side, right? This
yes,
was
ma'am.
new. This was not there in the previous imaging. This is there in the T2 also. This is there, right? We are not sure what we are looking at. Okay, let's
Yes,
go to gradient also. So there is some bleed here. There is a new area of bleed. Okay,
yes,
because it's
ma'am.
blooming on gradient. And
Yes,
let's see the post contrast. This one is actually hyperintense because of the bleed. This is the intrinsic T1 hyperintensity which is present. I just will see whether there is any pre-contrast T1 available or not. This is all post-contrast only. Okay. This is the pre-contrast T1. Yeah, so it's hyperintense and pre-contrast T1 only with blooming. That means it's a bleed. So there is a new focus of bleed here. There, the lesions in the left frontal and the left thalamus are still there. The rest of the lesions have gone. So we
yes,
were not very sure again what we were seeing, right? So we
yes,
just gave the patient again an observation. She was there on anti-epileptics and she was always receiving the treatment for whatever T cell lymphoma she has had. And it is very important to remember in this particular case that this patient has a very, very strong family history of malignancies, right? Again,
yes,
if we go back to another MRI, this one. This is done in September 2023. Just let us see at what these lesions look like. Right. Can you describe it now?
yes, ma'am.
Soundar,
Yes, ma'am.
please tell me what are you seeing?
We can see the left frontal region. The lesion is persistent, and it is also seen in the left thalamus, and we can see in
So
the right.
therefore, it has increased, right? It was
Yes,
less
ma'am.
prominent, but now, especially the basifrontal component and these areas have become definitely much more prominent now. The
Yes,
another lesion, which was a bleed, which has now resolved. There is some
resolved.
staining here. Yeah, that is the some staining is there. And let
Yes,
me show you the post contrast image. Okay, so there is not much of an enhancement. Yeah, there is one focus of enhancement which has now come up. There was no enhancement in this particular tumor in previously, but this new focus of enhancement has come up. And there is one small DVA which you should not miss. This is the DVA, right? What is the DVA?
developmental venous
So
anomaly.
the developmental venous anomaly is also present in this patient. It was there previously also, but we could not get any proper post-contrast sequences. But then this is now very well seen in this. Right, so we have a lesion which is evolving in the left frontal lobe, a stable lesion in the left thalamus, a lesion which is possibly a small focus of bleed, and we presume it's a small cavernoma which was bled and it has resolved, and another small DVA which is very well identified in this case. The rest of the lesions have evolved. Okay, they have resolved. So let's come to the final MRI. This is just before the patient was taken up for surgery. Now you tell me. Tell me, Adarsh, tell me what we're seeing.
And there is a significant increase in the hyperintensity, and there is also a well-defined hyperintense lesion
So the area which was showing that nodular post-contrast enhancement is actually
has
blown up
increased.
now, right? It has significantly increased. The rest of the lesion also appears much, much prominent. The thalamic lesion looks fine. There is a lot of mass effect from this. It is compressing the frontal horn of the left lateral ventricle. So that's that. That the lesion has significantly increased. Let us look at the flare and post-contrast. Right. So this is a post-contrast flare. As we told, we acquire a post-contrast flare. So this part is showing intense post-contrast enhancement. So definitely that is the higher grade part of the tumor. There is another small focus of enhancement which has come here. And let me say the diffusion also. Yeah, so rest of the tumor is showing free diffusion, whereas this part of the tumor is showing some amount of restriction. No, that is also not showing much, but maybe mild, plus minus, not
Yes,
very
ma'am.
significant, right? So this is how the tumor looks like, and let us see this. So again, we can just see that the DVA is there. It's a touch and go, but then definitely it is there. Okay, this lesion in the left temporal pole is stable, it has not grown. So this is a very interesting case. Whenever you have a very strong family history of malignancy and you see a lesion which looks like a glioma, you have to do a germline testing, which is known, this is basically a glioma in a patient of CMMRD, which is a congenital mismatch repair gene mutation related disease, which has specifically mutations of four genes, of which some MLH1, 2, and MSH genes they are there, and one more gene is there, PMS. I think I don't remember the name correctly, but basically in this patient, because she herself had a history of T cell ALL, and whenever these patients are very, they develop T cell ALL. So T cell ALL and glioblastomas in the brain, these are the common tumors which are found in these patients. So whenever a patient of T cell ALL presents with a brain lesion, we go back and do the germline testing. We go back to their family history and we see whether these patients have any family history of glioblastomas or not. Then we can tell that these are basically germline mutation related tumors. So this case is very interesting because this patient presented to us with seizures after on when she was in chemotherapy of T cell ALL. She had an episode of press. Then that press was resolved. She had, so these patients again have DVAs and small vascular malformations. That is also very important. So DVAs are a very common finding in case of CMMRDs. So a
Okay.
DVA was there in this patient, a small, maybe a small cavernoma with a DVA which has bled. That was also there, and this was a glial neoplasm which was slowly evolving over a period of 2 years, and finally when the patient was operated it came out to be a grade 4 IDH mutant astrocytoma. So in
Okay,
such
ma'am.
cases, this obviously does not, I did not mean to make a make you, or you should not make a diagnosis for this, but I just wanted to show you that how tumors can present to us and how careful you have to be when you're looking at a particular lesion.
Yes, ma'am.
Okay. So thank you for your presence and patient listening, and I congratulate you both for your wonderful performance. And I hope that this session was useful to you. And I'm open
Yes,
to
ma'am. It was
discussion.
very useful, ma'am. Thank you. Thank you,
Thank you.
ma'am.
Yeah, thank you, Kajri, for that amazing session and a fabulous review of brain tumor cases. A loud shout out to Dr. Sauntar and Adarsh for taking up the cases. It is not easy, and I'm sure you would have got a practice of your Viva vote also.
Yes,
Kajri, there are plenty of questions in the Q&A section. Can you just answer them? Uh,
Yeah, so please
and
explain how do you interpret exponential ADC. So if you look at how, so basically diffusion imaging, what does diffusion imaging tell you? Diffusion imaging tells you whether what is there any cellular swelling or what is the space in between the cells. So if the water is freely moving, the cells are of normal size and there is no obstruction to the movement of free water, then there is no diffusion restriction. If there is increased cellularity which is seen in tumors, then there is diffusion restriction, or if there is an ischemia which is seen in case of stroke, then there is cellular swelling which leads to diffusion restriction. When you acquire a diffusion imaging, you acquire two values typically for brain, that is a B0 value and a B1000 value. This is basically, this tells you the amount of change in the gradients which you apply for acquiring this. So B1000 is the basic value of a diffusion weighted imaging, base imaging that we acquire. So out of that, the second, so diffusion imaging, that is the base imaging. After that, we look at the ADC. So whatever is hyperintense on DWI is black on ADC, it means it is a true diffusion restriction. Exponential ADC is basically a subtraction of this from this. So something which is appearing hyperintense on exponential ADC, it is showing the true diffusion restriction. That means something which is hyperintense on DWI but not hypointense on ADC, that means there is no diffusion, true diffusion restriction. Okay, so ADC gives you one shot answer to whether there is any true diffusion restriction because it subtracts the B1000 value and the ADC from the B1000 value and gives you the area of true diffusion restriction. Okay, so I think B1000 ADC images I've explained already. Next is the basic question. Could you show how we differentiate parietal and temporal and parietal and frontal, especially in axial sections? Okay. So this is a good question and I like anatomical questions. So I'll go back to the first case again. Okay, I'll show you in this one only. Okay. So this was the case, right? Mm-hmm. So in axial sections, if you want to see, so this is the temporal lobe, right? This is the temporal lobe. Next is, this is the insula. So this part is your uh, uh, anterior part of the temporal lobe. This is again the basifrontal lobe. So this is separated by the sylvian fissure. So this is your temporal lobe, this is your basifrontal lobe. Again, we move up, insula, frontal lobe, temporal lobe. So when you see that your ventricles have joined, above that is basically your parietal lobe, right? So if you generally see above the level, so if you see at the level of corona radiata, when your basal ganglia have gone, then you can say more or less that you have arrived at the level of parietal lobe. So this will be your parietal cortex. So this is a very rough estimation. Actually, you should go by, whenever you're looking at MRI, by the correct anatomical localization, and that happens only when you see axial, coronal, and sagittal planes all together. So particularly coronal plane helps you a lot in localizing. So when you're looking at the coronal plane, this is your insula. So this is the temporal operculum, this is the frontal operculum. So obviously this part is the frontal lobe, this is the brachyfrontal lobe, this is sylvian fissure, which is delineating the frontal from the temporal. So this is the temporal lobe. And when you go more posteriorly, this part is your parietal lobe, right? So parietal lobe here again comes more posterior, after a lot posterior than the when you read the region of the tail of the caudate nucleus. So this is all the parietal lobe. Again, if you see in the sagittal sections, just go to the sagittal sections. Let's just look at the tumor. Right. So this is your sylvian fissure, right? So this part of your brain is the parietal lobe. The medial parietal lobe is very easy to see because medial parietal lobe has this parieto-occipital sulcus, and this is your precuneus, and this is the part of the central sulcus. So basically, this is the cingulate gyrus. So this part is the medial parietal lobe, and the lateral part, lateral part of the brain, if you come, this is basically teaching anatomy. This is the part of the frontal, and this is the part of the temporal lobe. This area contains many important supramarginal gyri, angular gyri, and superior and inferior parietal lobules. So this is very important. You go back and read your anatomy. There is no tumor in the parietal lobe. So you have to look in all three planes to see whether what part of the brain you are looking at. Next is this perfusion and spectroscopy. Now controversial to check for the grade of tumors. Spectroscopy. Yes, you can, but generally we do not rely on spectroscopy that much. We generally look at spectroscopy specifically in case of our post-treatment tumors, where we are looking at radiation necrosis versus progression. Perfusion is definitely helpful. Perfusion will tell you, so if the perfusion value roughly, it is told that if the RCBV is less than 1.75, it is a lower grade tumor. If it's more than 1.75, or some texts say more than 2, then the normal adjacent white matter, it's a high grade tumor. But yes, there are many more interesting and easily conventional imaging features which can tell you, like like diffusion, like SWI, if there are bleeds, there are new angiogenesis, and the post contrast imaging can give you that idea fairly nicely without doing the perfusion imaging. Yes, obviously perfusion imaging can help you in certain cases, but then still I feel that it is important when you're actually very confused about whether you're looking at a tumor or not. So if you're looking at an infection and you're thinking maybe it's a tumor, then when you don't see that choline peak and you see some amino acid peaks, then it is very easy for you to tell that in spectroscopy. And for perfusion also, tumors are generally hyperperfused, and these abscesses are generally hypoperfused. So in that case, it is very helpful. But for primary tumors, for grading, generally there are better ways in conventional imaging, but you can still perform. But generally, perfusion and spectroscopy is more helpful in post-treatment imaging rather than primary tumor grading. Why do you opt for post-contrast flare? In our setting, it is very important to understand that we make our diagnosis on T2 diffusion and post-contrast. Post-contrast flare is important because number one, it shows us very elegantly the areas of leptomeningeal enhancement, which is definitely not seen in a pre-contrast. It can be seen, but then that is definitely post-contrast flare is very important for us because we get a lot of metastasis. So the bulk of our lesions that we see in our settings are breast and thoracic, that's lung cancers, which often present with brain metastasis and subtle leptomeningeal metastasis. So our protocol of brain tumors is only shifted towards a post-contrast flare, but obviously a pre-contrast flare is a very good bet. If the ADC value is same as that of brain, do we still call it as diffusion restriction? You have to understand that your machine should be very well tuned. So in our setting, in our institute only, there are few older machines which are not that well tuned. So first you have to see that your parameters are correctly set, and secondly, if the ATC values are same as the cortex, it is not called as diffusion restriction. It has to be lower than that. But obviously, if you're looking at qualitative values, you have to properly adjust, and then only you can see. If you're looking at quantitative values, and quantitative values are more indicative. We generally hardly look at the quantitative values, but quantitative values are extremely important when, especially, you're looking at prognosticating a tumor. So if you're looking at a very high grade tumor and it has a very low ADC, it generally means that it will behave worse, because it has a very high cellularity tumor and it will generally not fully respond to whatever therapy you are giving. So in case of lymphomas also, it is said that if it's a very low grade ADC, it's in the tune of 300 or 400, it's less than 500. These tumors generally behave really bad. Next is lymphoma case. There is blooming and necrosis. Why isn't this a high grade glioma? It's a very good question actually. So there is a certain percentage of lymphoma, that is in the tune of 30%, which in immunocompetent patients will also show necrosis and um, uh, hemorrhages. Okay, so it is very important for you to understand that in SWI, in case of this tumor, we were not seeing any cases of neoangiogenesis. And it's extremely important to identify neoangiogenesis, and that is why we always prefer to take SWI instead of gradient, because SWI shows you those new vessels. The gradient does show you only a focus of blooming. So if you see those neoangiogenesis, then only you can say that this is a glioma. Second thing is, here the entire tumor was almost homogeneous, only a small focus of necrosis was there. And this necrosis, that's what I'm telling you, in immunocompetent patients also, in approximately 30% of the cases, we can see necrosis, and your general impression should be based upon the bulk of the tumor, the type of post-contrast enhancement, and the perfusion. In this particular case, actually perfusion helps you in telling, because it's a cold tumor, it's a very hypoperfused tumor, and you can actually see that perfusion going above the baseline. Okay, and next is, would the third case be a postictal phenomenon? Some people say only status epilepticus can cause changes in MRI brain. Yeah, so basically, I'm so sorry, I'm so sorry. So the question was, could the third case be just a postictal phenomenon? Some people say only status epilepticus can cause changes in MRI brain. So yes, it could be a postictal phenomenon, but generally postictal phenomenon presents with diffusion restriction. And if there is no diffusion restriction, it's a bilateral symmetrical signal changes present both sides, then you have to think more of press rather than a postictal phenomenon. Next is second case diagnosis. What was the second? So lymphoma. Lymphoma. Next is how to say it's a cavernoma that has bled, or it's a solitary bleed from a head injury, because sometimes history is not available. It is absolutely correct, and I completely go with you. It can still be. We were not sure what is the history. There was obviously no history of fall, but we are in when this finding was seen in that particular MRI, but it could very well be related to some trauma, but since this patient already had a DVA in one side of the brain, we presumed it could be that, but we were generally not concentrating on that because it resolved on its own and it did not turn out into something very malicious. But yeah, all the questions cannot be answered in this particular patient. I agree with you. Next is, was the perfusion increase in the last case with the glial neoplasm? Yes, it was borderline increase, not very high, because it was an IDH mutant grade, I think grade 2 to grade 3. But as far as I remember, it was not very high. Next is how to report perfusion weighted imaging. So yes, perfusion weighted imaging, first you have to understand the basics and how the perfusion is seen. So if you see the graph, you see a qualitative image. So I'll just show you the perfusion imaging curve. Okay, one second. So you see a few things. First is this. This is a qualitative imaging. Okay, so this basically tells you it gives you a visual idea about whether it's a hypoperfused or a hyperperfused lesion. Second is this. These are the this is an arterial input function graph which tells you whether. So generally, what I told you is this is how the tumor behaves. The blood, any kind of brain parenchyma behaves. Blood comes in, goes into the capillaries, and then it comes out into the venules, and there is some gap here. In case of highly perfused tumors, this gap is even more, and that gives you a visual idea about whether looking at a significant high grade tumor, and that translates into this graph. So basically you see the CBV and the CBF, and more important for brain tumors is the CBV. So if the CBV is very high, then you say that it's a, so if it's more than 1.7 in some texts and more than 2, then you say that you're looking at highly perfused tumor. So all these three things you have to look at, qualitative as well as the quantitative values. Okay, how to approach supratentorial interaction cystic lesions? It's altogether a different lecture. I don't think I can answer this question. MR spectroscopy, malignant lesion, choline versus creatinine, how much? These are all theoretical questions. Okay, so you know that it is somewhere around 2.5 to 3. In some texts say 2. So this is all. So basically, generally what we see is choline is to N. If it's more than 2, it's generally a higher grade tumor. But generally, as I told you, I don't rely on spectroscopy much to grade my tumors. Next is how to differentiate between lymphoma and glioma with spread along the ependymal lining. So basically, you have to look at the diffusion, you have to look at the age of the patient. The history is extremely important. Generally, lymphoma PCNSL is seen in elderly patients. You have to look at the type of enhancement, the type of diffusion restriction, the type of T2 signal. So this kind of subependymal spread with intense post-contrast enhancement is generally seen in lymphoma. But therefore, but still, I would tell you, in our joint clinics, in our meetings also, in around 30% of the cases, not 30% of the cases, in case of around some 10 to 20% of the cases, we are also really not sure whether looking at a lymphoma and a glioma. And in that case, is when all the advanced imaging kicks in. We look at the diffusion, we look at the spectroscopy, we also look at the PET imaging. So if we have a doubt, we get a FDG PET done. As we all know, lymphomas have a very high FDG PET uptake as compared to gliomas. And another battery of tests, which is what we do. We do an IL-6 from the CSF, IL-10. So all these markers, they actually tell you. So there is a literature, there is a guideline, IPCG criteria, which tells you actually that you have to look at the CSF values of IL-6, IL-10. You have to look at the ADC values. You have to look at the PET, and then only you can tell that it's a lymphoma or a glioma. So therefore, this differential is not very easy. But yes, if you see this kind of intense post-contrast enhancement, diffusion restriction, and a low perfusion lesion, then you can have some idea that whether you're looking at a lymphoma or not. CNS lymphoma versus multiple sclerosis. Multiple sclerosis not, but definitely diffusion, sentinel demyelination. So rather than tumefactive demyelination is often confused with CNS lymphoma. And often CNS lymphoma in some cases has been shown to present with a tumefactive demyelination. It looks like a tumefactive demyelination initially, and generally these lesions further evolve to be a CNS lymphoma. So we know that tumefactive demyelinations, they have an advancing front of diffusion restriction and open ring kind of enhancement. Those kind of things are not seen in CNS lymphoma. But you have to be very careful that if you're looking at a tumefactive demyelination, you follow it up. In some elderly patients, it has turned out to be a case of CNS lymphoma in future. Okay. Is perfusion the only way to comment upon the viability of the tumor? Absolutely not. Matlab, yeah, viability. What do you mean by viability? Is I don't understand. You mean radiation necrosis? So if you are discussing about post treatment changes, yes, perfusion is a way, but then you have to look at the other parameters also. You have to look at the diffusion. You have to look at, so there are a host of changes which happen with the drugs, which happen with the reduced radiation, which happen with the advanced treatment agents which we are giving, and therefore you have to look at the entire battery, and perfusion obviously is a very strong predictor of a tumor viability in those cases. In pre-treatment cases, I'm not sure how to answer the question. Next is there any chance that there is an increased perfusion in the post-radiation change if there is no residual tumor like post-radiation hypervascularity? Generally not. If there is no residual tumor, generally post-radiation changes will not show any hyperperfusion. Radiation necrosis versus tumor, it's a separate lecture, but yes, tumor will show. This actually is not a part of this lecture. Yes, maybe I'll present it somewhere later. Yeah, if graph has separate implications other than that of perfusion color maps. Yes. So if something, for example, in the cases which I showed you, if it is not, a low grade glioma will also appear cold, a lymphoma will also appear cold, but that upshooting of baseline will only be present in lymphoma. It will not be present in a glioma. So then definitely it has an implication in that particular case. So in some cases, yes, obviously there is an implication how to differentiate ring enhancing low grade RCBV tumors versus abscess. Low grade ring enhancing low RCBV tumors are generally not seen. So if you're looking at something, so first, if you are looking at abscess versus a ring enhancing RCBV tumor, generally the tumors which you confuse with an abscess, they don't generally don't have high low RCBVs. If it is looking, it's a necrotic ring enhancing lesion, it is generally a high grade tumor, it is never a low grade tumor. But yes, if you're looking at something like a pilocytic astrocytomas which may have that ring enhancement with a mural nodule, but then it looks altogether different, and it's different imaging features, different diffusion restriction characteristics. So what I mean to say is you have to look in the tumor imaging or in totality, and specifically all three T2 diffusion as well as your post contrast elements in togetherness. We should know what looks in each of them, and still if you are confused, then you go ahead and perform the advanced imaging. Please press in frontal lobe. Usually press occurs in occipital. Yes, press usually occurs in parieto-occipital region, but frontal is also an area. Posterior fossa is also an important area. Sometimes brainstem is also involved in press. It is not only that only the posterior parietal involves. And it was not only the frontal. If you see the entire imaging, the occipital areas, parietal areas, every area was involved initially, because initially it was press, but obviously it was a tumor with press. Tumor was an incidental pickup. The seizure was predominantly due to press, but then it was an incidental pickup, and slowly it evolved into the tumor which is there in the last 4 years. So with that, I think I've answered everything. So can we
Yeah.
end the session?
We need to catch some breath.
Yeah.
That was fabulous answers to almost 50 questions, and just shows how much demand is the brain tumor and you are. So
Thank
there
you
are
so
already
much.
requests for your subsequent session in the chat box, and she's already promised us one more session in April. Thanks for being so generous with us, and it's lovely to have you on this platform always.
Thank you so much for your for giving me this opportunity and for those amazing kind words. Thank you so much.
Yeah, my pleasure.